Okay, that's great. Let's have a look here. Great, well, welcome everyone, and it's going to be a quick sort of lunchtime broadcast. But what we're going to do is sort of go through this, the Great Barrington Declaration. So it's been in all the papers today. Skip to the sort of top scientists in the world who have written this. I think the first thing to say is we often see that there is this interest in the media and generating debate and creating the argument that there's two sides to every argument, when actually in science that is not the case, and climate change is a great example. 98% of scientists agreeing, broadly consensus, that climate change is real and is changing, and 2% not, but always pitched as a debate in the public, and we're seeing a similar sort of thing here. Having said that, there are some valid points being made, and some real experts who have signed this letter, so I think it's reasonable to have a look and to go through it, just from my sort of moderate layman's perspective, and for some mutual benefit. So it's called the Great Barrington Declaration. I don't know why it's called that. And I thought we'd just have a read it, and we'll just have a Google as we go through, as we normally do. So as infectious disease epidemiologists and public health scientists, and actually if you go through the list of people here, some of them aren't actually either of those two, but many of them are. So it's just important to note that not everybody that's signed it does fall into the category. We have grave concerns about the damaging physical and mental health impacts of the prevailing COVID-19 policies, and as recommend an approach we call focused protection. Coming from both left and right and around the world, devoted our careers to protecting people. Current lockdown policies are producing devastating effects on short and long-term public health. I think this is pretty interesting, so why don't we stop there and let's look at, well, what actual effects do lockdowns, and this is just a whole bunch of resources that we put together, lockdowns actually impact on public health. So the first thing to say is we can look at the excess deaths. So why don't we look at the excess deaths in the UK and have a look at the pandemic. So here is a graph from the Health Foundation. This is the excess deaths over the last year or so, leading back to June last year and up to around now. And over the period of time we can see that this is the pandemic, with a very high number of excess deaths in the UK, probably around 50,000, 60,000 now. And on the death certificate we can see that deaths involving COVID made up the vast majority of that, about 75%. And similarly, we can also see that there's this non-COVID increase in excess deaths, and that's about 25% above the 5-year average. Now the first thing to say is, and this is what the ONS and the Health Foundation have noted, is that if you look at this pattern over the course of the pandemic, so the lockdown came in around here, 24th of March, and continued with pretty much the same strict guidelines until the end of May, beginning of June. But you can see that there's a clear rise and fall to the non-COVID deaths as well. And one of the main hypotheses here is this is actually undiagnosed COVID, and we saw about 6,000 deaths increased above the 5-year average in Alzheimer's and dementia deaths, as well as symptoms which are unexplained. And it's not unrealistic at a time when there was no testing and autopsies were very much decreased in terms of referral, that we don't have a COVID cause of death here. But it does follow the same pattern. That's not to say that there aren't significant impacts, certainly, of lockdown on other forms of mortality. So if we go back and look, so this is an interesting study that's been doing the rounds on Twitter, and what they did here is there's 67 or so referrals to the John Radcliffe Hospital in Oxford for post-mortems, and these were sudden unexplained death post-mortems which required a cause of death. Now it's quite useful there to maybe talk a little bit about the process when you die in hospital. So the first thing that happens when you die in hospital is that a doctor who's been looking after you will verify that you have passed away, and that's a very simple mechanical procedure where we check for breath sounds, life sounds, and heart sounds, as well as response to pain, response to name, and a pupillary response. Once we've verified the cause of death, then we go on to write a death certificate. Now, if there's no controversy, or we can all agree what the cause of death is, then we don't need to necessarily refer to the coroner to work out what the cause of death is. And that would be the majority of deaths in hospital. The diagnosis is known, and often the death is expected. There are some certain categories where death should be always discussed with the coroner, specifically around when we do operations, when we do procedures that may or may not have contributed to the death, and if we suspect there's any sort of untoward or any other cause that needs investigating. So what's quite interesting here is that in 2018 there was 105 referrals over this period to Oxford, and during the pandemic there was about 67, so well under half the normal value. And that's because probably that lots of the infection control measures, especially around COVID, transporting bodies around, were much stricter. So the threshold for referring was much lower. And you can see that there's a big drop-off in the referrals cause of death, sudden natural death. Now, this obviously then is a very different cohort of autopsy patients to what you'd expect. And because the threshold's been raised, any sort of death that looks like COVID wouldn't have been referred for autopsy, would have been discussed with the coroner and just gone on without needing any necessity. Wave noise. Oh. Sorry, I have to turn the wave noise off. Okay, that's much better. So the autopsy results, therefore, is very interesting. So there was a small rise in suicide, there was a small rise in alcohol and drug misuse, there was a big drop-off in sudden natural death, and a big drop-off in trauma, which we'll come back to. COVID-19 made up 2 out of 67, so there's a lot of people have taken this paper and said, well, actually the non-COVID death looks like it wasn't COVID related, but this is a very small sample, and as I said, the threshold for referral to autopsy was very different. But there is a significant impact here in terms of suicides and alcohol drug misuse, which we cannot ignore. So if we go back then to the actual impact on age groups, so we can see here that this is the non-COVID excess deaths here. So after the course of the pandemic, the non-COVID excess death went below, as all excess deaths did in this country, went below the 5-year average. So excess deaths decreased substantially. So first of all, the thing to say is the long-term lockdown effect has had no discernible impact on the causes of excess death after the pandemic, which is the first proposition, that the causes of excess death caused due to lockdown are greater than the deaths that we had with COVID, which is clearly not the case. The second thing is, which we never talk about, is there are lots of mortality benefits to lockdown measures. So if you look at the children, so the age from 0 to 20 to 29, these were increased, there's normally a 5-year average here of mortality, and you can see that during the lockdown times, all of the excess deaths were in the negative. So excess deaths in children and young people dropped significantly. And this is probably because about 75% of deaths in this group are due to injury in road traffic accidents. There's much less people on the road. We still have 30% people working from home right up until September in the UK. So we have a obvious argument for that, in that simply people are less on the road and less children are dying as a consequence. The other thing to note is that even in the older age group, 60 to 69, 70 to 79, after the first wave of the pandemic, excess death dropped into the negatives again. So overall, the impact on death is low. The second thing to say is there was a good study that again made all the papers in a few years ago, so a few months ago now, looking at the mitigated and unmitigated scenarios of what the impact of lockdown actually was. And it was made all the papers because it said the impact of lockdown will be around 75,000 deaths, which we took to mean was more than the number of deaths that there were over the course of the lockdown period. So this paper is from, I'll just open up for you, is from the SAGE group, and it was presented on the 15th of July. It's a very long paper, it's about 188 pages. But the most important thing to say here is that they did actually calculate the impact, the non-COVID impact of lockdown measures exactly. And there was a pessimistic and a optimistic view of this. And the pessimistic calculations were about 25,000 deaths. But the optimistic calculations, and I'll just try and find them here for you, were actually in the positive, because the number of deaths that otherwise would have occurred, if we look at so this is the optimistic estimate, and you can see here, it's very interesting, that they actually estimated that alcohol and drug misuse would go down, but significantly air pollution deaths, because of the number of less people commuting, would also decrease. So here, in the most optimistic illustrative analysis, the impact of lockdown was actually positive. 800 lives were saved. And in the most pessimistic, it was 52,000 lives were lost, or will be lost, I should say, over the next couple of years, due to a combination of the actual lockdown effects plus the long-term impacts of recession and poverty on many other medical conditions, and it came out the number of about 25,000. So the important thing to say here is that there's very little evidence of a short-term immediate impact, at least on deaths. There are significant evidence already in the service for cancer and cardiovascular care that there has been a big impact because of lockdown. But we have to then take a step back and say, well, why was that impact of services in the first place? And that was because of uncontrolled coronavirus. And the third thing to say is, in this paper, if you actually look all the way to the bottom, it talks about what would have happened in terms of number of deaths, non-COVID and COVID, if we had an unmitigated scenario where we didn't do anything at all. And in that circumstance, it estimated that there would be about 1 million lives lost and a further 500,000 lost as a consequence of overwhelming to services, which is about 1.5 million extra deaths. So again, this idea that lockdown measures were in any way disproportionate to control the number of deaths, well, in this particular paper that has been widely quoted as an example of the impact of lockdown, 1.5 million deaths were estimated from the same calculations would have been in what we call the unmitigated, with no lockdown, with the herd immunity strategy. And that's from COVID, but also from overwhelming the hospitals and completely reducing all cancer and cardiovascular care. So what happened in the course of the pandemic and over the period of time earlier in the year was we did see an impact on cancer care specifically and on cardiovascular care. But the issue really is, well, why did we have those impacts? Well, screening services were cancelled to control number of people coming to hospital, but also the staff, because they were redeployed to deal with COVID. Similarly, cardiovascular care, we saw big drop-offs in referrals for cardiothoracic surgery, which we can't do because the ITUs were full, the anaesthetists were redeployed, cardiologists like myself were also redeployed to intensive care. Because we essentially had an extra 3,500 intensive care patients and 13,000 over the whole period. So this idea that you can choose one or the other, it doesn't make any sense. In fact, it's quite the opposite. The only way to protect cancer and to protect surgery is to aggressively control in the community the avoidable causes that block up all these services, which is namely COVID. So this idea that there's significant evidence that there's a long-term impact from lockdown, unfortunately, doesn't really, so far at least, doesn't really stack up. I'll just briefly mention the impact into cancer care, because I think that's important. So over the course of the lockdown, cancer treatment dropped by about 30%. This is some statistics from Cancer Research UK. And screening dropped significantly by about, with backlogs now of about 3 million. So the first thing to say is that if you look at countries that controlled the virus very early and very well, such as New Zealand, they were back to normal and restarted their screening programs within a couple of months, whereas we took almost all the way back to the summer to be able to do that. The second thing is the number of people on screening programs. It doesn't necessarily equate to that. I mean, it doesn't at all necessarily equate, because they're screening programs of well patients. So it's actually an additional, we're thinking about 3,000 cancer deaths from the commonest subtypes of tumour induced delays in care, and that's what this study sort of had a look at. And the last thing to say is some cancer patients still seem to be at risk from COVID. So creating a safe environment and a safe community means they can go about their daily lives and go about their treatment in a much safer capacity. So again, controlling the virus in the community is the way to protect cancer and heart patients and the services in general, and we know this. Okay, let's go back to the letter. So, kind of left and right, fewer cancer screenings and deteriorating mental health, leading to greater excess mortality in years to come. So again, we've looked at the estimates, and they are far below the estimates that we would have if we had uncontrolled virus in the community. But it's not either or, and that's an important thing to think about, but we need to look further into this. Keeping these measures in place until a vaccine is available will cause irreparable damage, with underprivileged disproportionately harmed. So again, this isn't the case in many, many countries in the world. So for example, New Zealand, almost fully back to normal in terms of healthcare service, fully back to normal in terms of economy. South Korea only had 1% GDP drop. Germany also doing very well controlled. And they're taking the intermediate measures of test and trace, social distancing, and opening things back. Lockdown measures are not a way to treat the virus. They're a way to suppress the virus when you have no other options. We didn't take any other options at the beginning of March, and we ended up going straight into lockdown, which was initially basically our first measure. We didn't control working from home. We didn't have social distancing. We didn't advise people to be washing their hands or wearing masks. And we walked straight into a very late lockdown, which had to be very hard and very prolonged as a consequence of that wait. But if we'd gone early, we could have come out shorter. So all of these interventions are very much predicated on how early you go and how hard you go at the time. So, and we know all this again. So the idea that we can get away without doing lockdowns at all is possible, but we need to have a controlled level of virus in the community, which means a functioning test and trace, and it means 100% compliance, as close as in the community, with social distancing, hand washing, and mask covering to reduce the spread of the virus. And if we can maintain that, then yes, lockdowns are necessary. But if we can't contain that, then I haven't heard yet a coherent argument of what we should do. And I suppose that's what we're trying to look at here in terms of what else we could do in that circumstance. So fortunately, our understanding of the virus is growing. We know that vulnerability to death from COVID is more than 1,000-fold higher in the old and infirm than the young, depending on your comorbidities and your age and your sex and your income level as well in the country. And indeed for children, COVID-19 is less dangerous than many other harms. So this is looking at mortality, number one. The second thing is that we don't quite yet understand what the long-term effects on what we call morbidity, which is the long-term illness. So if you are a young patient and you catch COVID and you get mild symptoms, something up to 50% will have significant lung changes on their CT. And we're seeing in lots of studies that very high numbers of patients don't feel quite right for a number of months after they've had their what's supposedly a very mild illness. And this is the phenomenon of long COVID. And again, if we let it run through the population without understanding that, we might end up with a very sick long-term population, which has the same economic consequences as a short-term lockdown would, and possibly worse. I'm just trying to get that sun out of my eyes. I can't do that. Okay, and then we say, as immunity builds in the population, the risk of infection to all, including the vulnerable, falls. I mean, that's fair enough. We know that all populations will eventually reach herd immunity, i.e. the point of which new infections is stable, and that this can be assisted by, but is not dependent on, vaccine. So that's an interesting point, because there isn't, or has never been, a virus in the community which has reached significant levels of herd immunity without a vaccine. For example, polio was eliminated with a vaccine, measles was eliminated, or nearly eliminated, with vaccinations, and then we withdrew vaccinations and we withdrew that herd immunity. But in terms of a severe, continuous virus in the sense of this, that's never been achieved through herd immunity. And certainly if you look at other coronaviruses is a bad example. They were controlled but by the same measures that we're taking now, mask wearing and quarantine, so SARS and MERS in very low numbers. And we've never reached a state like this before. I.e. the point at which our goal should therefore be to minimise mortality and social harm until we reach herd immunity. So I think the proposal here is that we reach herd immunity, potentially by a vaccine, but mostly by new infections, which the best measures are still going to be high numbers, 50, 60, 70% infection, which is significant. The most compassionate approach that balances the risk and benefits of reaching herd immunity is to allow those who are at minimal risk of death to live their lives normally, to build up immunity to the virus through natural infection, while better protecting those who are at higher risk. We call these focused protection. So this is where the logic sort of starts to fall down a little bit. Yes, you could, if you knew everybody in the population who could achieve herd immunity, if you could expose them all. But the problem is, A, we don't know who is at risk in terms of the long term. B, we don't know who is at risk per se in the younger population. If there's a high prevalence of undiagnosed risk factors like diabetes, high blood pressure, they might not necessarily know that you're at high risk. And the best estimates measures about 30% of the population would fall into the highest risk category, not the moderate, but the highest risk category. So that only leaves a very small number of people, about 70% of the population, which might not be enough to generate herd immunity in the first place. And the last thing is, if you infect all these young people with coronavirus as your actual strategy, well, where is the long COVID in that? Where is the long-term morbidity? And we might end up with a very, very, very high number of chronically sick patients with the same economic and health burdens effects that we would have from any lockdown measures anyway. And they call this focused protection, but they don't offer a lot of specifics. For example, if you live, many people live in intergenerational homes, in schools, they might work in public-facing jobs, and if you have to take 30% of the population and you say shield and don't be part of the wider community, well, one, that's, and we have to remember that countries in the world are back open. New Zealand is open, Singapore is open, South Korea is open, so this is possible. But if you decide you want to go that strategy, then you're essentially putting 1/3 of the population into forced imprisonment. And from a moral point of view, that's very dubious indeed. But from a practical point of view, it's not really possible. We're talking about 25 million people withdrawing themselves from the economy. So that's a huge economic blow. From the workplaces, from childcare situations, if you have elderly grandparents looking after children, if you live in an intergenerational home, you have to move out. This isn't a sustainable or practical solution, and it may require substantial funds, maybe even more funds than an economic hit, to make this actually a reality. Adopting measures to protect the vulnerable should be the central aim of public health responses to COVID-19. And I don't think anyone's going to disagree with that. And from the very beginning, we've talked about, the care homes weren't protected properly the first time, and we need to take much better measures to do that. But a lot of these things, again, aren't really sustainable. So, by way of example, nursing homes should use staff with acquired immunity. Well, we don't know that there is such a thing. And that's the biggest problem with any herd immunity strategy, is we've seen that antibodies from serology studies wane significantly after time. In many other coronaviruses, the antibody immunity only lasts 6 to 12 months. So this idea that immunity somehow confers that you can't be infectious, or we should be doing regular antibody testing, again, doesn't stand up to repeated evidence-based testing, and no one's tried to do this in the entire world. And perform frequent PCR testing of other staff and visitors. I mean, yes, again, this is possible, but depending where you are in an infection, you could be in an infectious phase right at that point. You could equally test positive and then be off for many, many weeks. And how do you then staff the hospital safely? So again, we don't have a lot of staff. We don't have a lot of stretch in the care home or the healthcare sector. So if we are saying that people who need, if we're going to just continue with widespread community prevalence and somehow manage to not leak that into our healthcare sector, essentially the buffer is going to be the staff. Now that fails on two levels. The first level is that if people are positive and they stay positive for 3 or 4 weeks, then a small outbreak amongst the staff, maybe 3 or 4 staff, would be sufficient to make your actual care very, very unsafe very quickly. And if the prevalence in the community is particularly high, as a herd immunity strategy would imply it would have to be, then loads and loads of staff might be positive. And these are people who have their working lives and are young people, so they're the ones that you're trying to infect. But how will you not infect them in this strategy? And there's about 3 million care workers in this country. So that wouldn't work, really. And staff rotation would be minimised. And the other thing is, we've had 640 odd healthcare worker deaths in this country. Now, if you go back and compare it to previous pandemics like flu deaths, it's very hard to find a comparable number. And the best estimate, this is 4 times as many deaths for any iatrogenic infection, so caught at work, for healthcare workers compared to flu or any previous pandemic that we've seen in this country. So again, this idea that we can just plough on regardless, knowing the danger to healthcare workers, knowing the danger of long COVID, knowing the impossibilities of what of this is proposed, is actually very, very dangerous. And again, this is where the sort of practical element of this falls down. We should be doing the maximum to protect the vulnerable, but the best way to protect the vulnerable is to reduce levels of virus for everybody, and that makes everything safer. Opening shops, opening schools, protecting care homes, protecting cancer care, cardiac care, hospital care, etc., etc. Retired people living at home should have groceries and other essentials delivered to them. So essentially this is arguing for the return of shielding and supported shielding, which I actually would support, and many people would support. We are already at number of more cases today, even if you allow for the increased number of testing, than we were on August 1st when shielding finished. So the risk was low then, low enough that people could come out of shielding, but we far exceeded that threshold again. And one of the most sensible things, without much economic damage, would be to encourage those on the extremely vulnerable list to go back into shielding, to be financially supported to do so, as is sort of suggesting here. And when possible, they should meet family members outside rather than inside. Again, that's a very reasonable suggestion. We know that outside ventilated areas are much safer than inside areas, and we should all be doing a lot more. Just out of interest, if you look at the mobility data in lots of the Nordic countries, so Sweden, Norway, their increased use of parks, particularly, so outside recreational areas, has increased by 300%, whereas in this country we only got to sort of 50 to 70% increase, so we could certainly be doing a lot more outside. Again, as the weather changes, this might not be that practical, especially if you're elderly. A comprehensive and detailed list of measures, including approaches to multi-generational households, can be implemented. So this is the fundamental crux of this argument. If you're going to argue for focused protection of what essentially will be 20 million, 30 million people, then you're going to have to provide some of these specific measures because they're life-saving measures. And I suppose one of the things that I find so difficult about a lot of this is that in a pandemic, your public health and public opinion is basically your only treatment. So intervening in that treatment without a strong recommendation or consensus in the science of what you're practically going to do can only serve to erode public opinion, which is very dangerous. And again, this isn't something that's been published in a peer-reviewed journal or a scientific process. It's been in all the papers and it's been in the media without that scrutiny. And this is a very big problem, especially in countries that are really struggling, in the UK and the US, for example, to control the virus because of public opinion and because of compliance, which is really the only thing that we still have to control the virus at all. And it says as well within the scope and capability of public health professionals. So if you look around the world at the best public health responses, so for example Vietnam, in fact lots of places in sub-Saharan Africa, so places where they have very, very little, compared to us at least, in terms of resources. And what do? They had widespread social distancing, very high compliance, because especially in Vietnam and sub-Saharan Africa, they're very used to pandemics and epidemics, and they also understand that there's very little resources if things go wrong. So no one on the planet has tried this strategy, and as I said, unless there's some very significant measures that they can actually produce that will show this can practically work and cost it out in terms of actually the cost benefit of maybe just a suppression strategy and reopening the economy, for example, like in New Zealand, then this isn't practical and actually, in my opinion, dangerous. Those who are not vulnerable should immediately be allowed to resume life as normal. Well, A, who isn't vulnerable? And B, what does life as normal mean? Because ultimately, there's no need for, there's no economic impact to mask wearing. There's no economic impact to social distancing, staying 2 meters apart. There's no economic impact to washing your hands. There's a mental impact, certainly, but I think what we need to have is clear messaging that these are the things that we should be doing and not having to have lots of social gatherings. But we know that cases are rising, and in the midst of this, people are encouraged to go back to normal life and say, actually, we should just protect the elderly. Well, even if you just limited that to the over 65s, that's still 20% of the population. That's a massive amount in most Western civilizations, most Western cultures. And again, why Sub-Saharan Africa might have done quite well, because their proportion of the elderly is much smaller as a percentage of the population. So these are not practical suggestions, and actually it would focus and paradoxically push more infection into that moderate risk group, and we would see even small complications become very common and risk overwhelming healthcare services again. And again, what's the timescale of this? Because if we do hygiene measures and it takes a while to get to that herd immunity threshold that they propose, we might see, or probably will see, an overwhelming of the healthcare service regardless, because there will be some spillover. This is not going to be practical even to the high risk groups. And the second thing that we'll see is lots and lots of long-term conditions as a consequence. And when you try to do this strategy, you end up concentrating a lot of people into the moderate risk group. And then, again, would increase risk in the younger population. Schools and universities should be open for in-person teaching. Well, yes, we could open schools and universities if there was very good control in the community. And in lots of places have opened schools and universities again with social distancing measures, recognising that these are, a cost benefit of keeping the virus low in the community. Extracurricular activities such as sports should be resumed. Young, low-risk adults, again, we don't know who they are, should work normally rather than from home. There's no rationale for this other than an economic one, which we can support, and we should be very imaginative in how we support people to work from home and to transform their working environment and to not lose their job as a consequence. Because what you can't practically do is give people genteel advice about working from home but not support them to practically do so, because they won't be able to do it, and then your compliance measure only harms those in the lowest socioeconomic groups. And similarly, asking, for example, intergenerational households to separate harms again those in the lowest socioeconomic groups. So this is a very inequitable policy, and is not going to be very sustainable. Restaurants and other businesses should open. Arts, music, sport and other cultural activities, I would agree. We should be trying to think practically about how we can get some of this stuff open. But the best way to do all of this is to suppress the virus to levels where it's very, very low in the community and we don't need to take any risks. The risk is much lower when we do take it. People at high risk may wish to participate if they wish. So this is a difficult thing, because lots of people might want to participate. And actually, things like this where they're told they're low risk and they find out otherwise. But then if they find themselves using healthcare services again and the healthcare service becomes overwhelmed, for example, say you're 60, you don't know that you have diabetes and high blood pressure, but you don't meet any of these high risk and you want to go to the football and you catch COVID there, or more likely catch it on the way there, on the tube or the bus, etc. And then you come into hospital and you're very sick and you need a ventilator. At no point is any doctor going to say, well, this was your risk. That's just not how it operates. We would prioritise always on, who has the best quality of life chance, who has the, what we can do futile wise. And then you're taking a bed away from somebody else who might be waiting for elective operation. The resources are only so finite. So this idea that, people can do as they wish, it doesn't really correlate with how we manage the holistic as a whole. And your choice to go and do something might end up taking away the choice of somebody else who needs a knee operation or a hip operation or a cardiac operation or cancer operation. And then lastly, people who are more at risk, blah, 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 while society as a whole enjoys the protection conferred upon the vulnerable by those who have built up herd immunity. So the last point is, if 30% of the population are at high risk and need to self-isolate, well, what happens on their immediate return? You lose herd immunity because now only 70% of your population is at risk. And unless there's a vaccine coming in the next, widespread use in the next sort of 6 to 12 months, and almost indefinitely putting these people in their homes with the same economic and health risks. So I think there's a lot here to unpack, and there's a lot here that is very impractical. And actually, a lot of this has stuff already people have criticised. So if we look at some notable names, expert reaction to the Barrington Declaration from a whole bunch of respiratory and public health doctors, they say very similar little things. It's not very clear how they're going to relay their focus protection. And each year we do focus protection. This is a very good point made by Dr. Tang, who get vaccinated. So we vaccinate the elderly and those at risk, and that's how we do our focus protection. But we don't have those tools yet for COVID, but we will have them soon. Dr. Rupert Beale has said declaration prioritised just one aspect, when actually we could fully identify, it's not possible to fully isolate them, and we know that immunity wanes. So all of these problems with the herd immunity theory are well recognised. The letter completely ignores all those problems. It also ignores all the long morbidity, and also ignores the practicality. So all we're really doing with this letter is generating a lot of angst and frustration in young people especially, who think that actually this should all be over and I should be allowed back into my normal life, when that's the strategy that is now, we saw in the summer, was the group that drove a lot of the cases as they rise, and now we're seeing hospitalizations and deaths increase again as we lost control of the epidemic through a poor track and trace system and no contact isolation. So we are stuck in this back and forth, and what's really frustrating is direct access to public opinion through preprint and media, and actually it's not a consensus opinion at all, and these are a very small group of, well, let's have a look at them, group of scientists who have declared this, but this isn't by any means the national consensus, and all the major bodies do not support this idea, the WHO, the CDC, the EDC, and others. So again, it's dangerous, I think, in my opinion, in a public health emergency to be so, I think, flippant, really, with public opinion. But again, we're seeing this picked up by politicians as this is definitive evidence of we should be doing something differently. But it just muddies the water, and muddies the water in a way that a public health emergency, that is disaster. So there's some epidemiologists here, and then some co-signatories, some of which have epidemiology or microbiology experience, and some who don't. And then there's a whole thousands of other medical practitioners, etc., who have written in support. But I would say there's a lot of practical issues here that need unpicking. There's certainly some useful and interesting areas to talk about. And again, I'll be talking later with Matt Strauss on DigiDebates about 6 p.m. GMT time, going through some of these issues about lockdown even more. There's a few questions, so let's just take them. What did the 2016 simulation exercise predict? So Operation Cygnus was performed in this country actually based on a severe widespread flu pandemic, and it showed many of the problems, that we were insufficiently prepared with ventilators, with personal protective equipment, with staff training, and we didn't take any of those measures, and then COVID came along and we had the same issues. Matt Hancock said that cancer patients won't be treated unless COVID is under control. So I don't know, I think his phrasing is not really, it's pretty inflammatory and is not really, raised in context. But broadly, again, it's a practical impact. The only way for us to focus on cancer care, which by the way was already in a very perilous state before the pandemic, and many of us have been talking about this for years. We've been missing cancer targets for 6 consecutive years in this country. Referral cards mostly through underfunding relative to demand. But again, if you are trying to run a screening program and you have 3 nurses who administer that program, or for example, if you are trying to run a endoscopy service and it becomes too dangerous because the community prevalence of COVID is too high, then those screening services get cancelled, and the cardiac surgeries can't run because you can't bring the patients in safely. You have to do more deep cleaning, you have to have specific staff, you have to separate the lists. It just takes up a lot of resources for what is an avoidable and preventable disease. And we've seen this around the world, that countries have controlled successfully, reopened and run their health services again. So it is not an either-or situation. You control the virus, reopen the economy, control the virus, reopen the hospitals. And cancer patients particularly are very vulnerable in both circumstances. They're vulnerable to their treatment being cancelled, and they're vulnerable to the virus in many circumstances if they're on chemotherapy. A bit less risk than we thought so initially, but if you are on chemotherapy and your cell counts drop, for example, you are still at pretty high risk. But that's true of almost anybody in any vulnerable condition, and what makes everybody's life and about to enjoy their lives and enjoy quality of life is working together, following the guidelines and keeping the virus as low as possible. There is no half and half situation, and it's just not practical that we would be able to achieve that. Okay, well, I think that's where we're going to stop. And as I said, 6 p.m. tonight will be on DigiDebates, and I'll put the link. I wonder if I can show it here. Why don't I try to show it? So with Matt Strauss, who's a Canadian intensive care doctor, 1 p.m. I don't know what EDT, but it's Canadian time, I think, and 6 p.m. GMT. So that's a little plug for that, and then we can talk about that a bit more at that time. I'm going to stop there, but as ever, send me any more questions, and we can, keep talking. Great, thanks so much.